This is Richard Wunderink, professor of medicine at Northwestern University Feinberg School of Medicine in Chicago. And I want to thank the organizers for the opportunity to present in this symposium on bacterial superinfections of COVID-19. I'm going to present some of our data on the role of bronchoscopic sampling and molecular techniques in diagnosis of bacterial infections. My conflicts of interest are with two diagnostic companies, bioMérieux, BioFire, which I'll talk about more, and Curatis, which is one of the competitors for rapid molecular diagnostics. So the issue of bacterial superinfection in COVID, ARDS, and pneumonia is controversial. The ATS-IDSA CAP guidelines strongly recommend empirical antibiotics for patients who have viral detections only. Now, this is mainly based on experience with influenza, and so it's unclear if that applies to COVID-19 as well. And the issue here is the concern about bacterial superinfection, which some historical data has suggested is the major cause of death in severe viral pneumonias. Now, as many of you who have taken care of COVID-19 patients know, patients are often admitted to the hospital for a substantial period of time before suffering respiratory failure and requiring intubation. During that time, they remain febrile, and because they have been hospitalized for up to 72 hours, there's this tendency to suspect that there may be new bacterial superinfection, including hospital-acquired pneumonia. And so what we were seeing early on in the pandemic is patients who were being transitioned to the intensive care unit were oftentimes on HAP coverage with vancomycin and piperacillin, tazobactam, or other combinations. Now, in our intensive care unit, the standard for severe community-acquired pneumonia was to do a non-bronchoscopic BAL to look for etiology and to also confirm that the patient had bacterial pneumonia. Now, a non-bronchoscopic BAL was contraindicated as an aerosol generating procedure because it was done in a somewhat open manner. And so we shifted back to bronchoscopy as our kind of standard. There's suggestion that bronchoscopy is contraindicated as an aerosol generating procedure, and that's clearly true when done in a non-intubated patient. However, the data in an intubated patient is much more unclear, and we felt did not have a contraindication. We did modify our bronchoscopy protocol for COVID patients, and the strategies were to minimize aerosol generation. We would do these bronchoscopies in the supine or prone position, and many of our patients were spending a significant amount of time in the prone position, at least early on. We used neuromuscular blockade or heavy sedation to minimize aerosol generation, and so for early BALs that I'm going to talk about today, it was often timed with the intubation to take advantage of the neuromuscular blockade used for that procedure. We would instill lidocaine in the endotracheal tube, especially if we were only using heavy sedation to once again minimize cough. As suggested, we used a disposable bronchoscope, and we used a IV pole that had a grab bag of all the needed supplies except for our non-bacteriostatic saline that we could take into the room with us. Once a timeout had been done, the RN and RT were asked to leave the room, and only one of the faculty, with or without a fellow, performed the bronchoscopy. We preloaded the bronchoscope tip into the ET tube adapter and had two strategies to minimize aerosolization as we put the endotracheal tube adapter in. What we evolved to is temporarily disconnecting the inspiratory limb of the ventilator tubing to place and remove the adapter. Earlier, we had just simply cross-clamped the endotracheal tube for those transitions. The details of our protocol are online in the reference at the bottom of this slide. Now, we also made use of the BioFire pneumonia panel menu. So we had been validating this just before COVID-19 hit, and rapidly developed an order set to allow us to use this routinely. If you look at all of the menu pathogens that are in red there, these are classic community-acquired pneumonia pathogens, Staph aureus, Moraxella, Haemophilus, the atypical bacteria, and it also had viruses. What is unique about the BioFire compared to the Curatus is the addition of the two additional strep species, Strep A galactea and Strep pyogenes, that were in this panel. In addition, it has gram-negative Enterobacteriaceae that are often or can be seen in community-acquired pneumonia, predominantly the ones in green. And there were two important resistance genes that were detected, one the MEK-A gene to look for MRSA, and the other is the CTXM gene to look at ceftriaxone resistance. So this pneumonia panel seemed to be very adequate for ruling out community-acquired bacterial pneumonias, as well as some of the hospital-acquired pneumonias. And we had previously validated this predominantly on hospital-acquired pneumonias, and this is just some of our preliminary data and I'll point out that the most important issue is the negative predictive value. If the PCR was negative, the probability of having that pathogen is extremely low. And so we felt fairly comfortable that we could rule out most of the nosocomial pathogens, but we're unsure about some of the strep and other species that were on that panel. Now, the next slide is one of the first observations that we made, and this is the proportion of cell types on our clinical cell count and differential in BALs. And what you can see is that there's a significantly higher proportion of lymphocytes in COVID-19 than there is in typical pneumonia. Typical pneumonia is about 3%, or our usual BALs, maybe 3% lymphocytes. The percent of neutrophils is actually decreased, and also macrophages are decreased, macrophages being the dominant cell type in many other, in normals and many other lavages in non-infected patients. Now, I'll point out monocytes. We were detecting these on clinical. They are transitioning into macrophages in the lung here, and these monocytes may actually be critically important in the pathogenesis of COVID-19. So clearly a difference from our usual BALs. And we're not the only ones to find this. This is a recent New England Journal article that looked at lymphocytic inflammation in a patient who died, and what you can see in the lower panel here is that there's a lymphocytic predominance in the lungs with very few neutrophils, and does not look necessarily like an ARDS pattern. In addition to just a higher proportion of lymphocytes, we also saw that there were abnormal lymphocyte morphology here. This is a slide courtesy of one of our cytopathologists who was interpreting these cytospin smears. And what you can see is the lymphocytes look very unusual compared to the one normal lymphocyte that we see here at the bottom. And you also see these monocytes that were relatively common in many of our BAL samples. So we actually had the advantage of having a very robust protocol to look at our BALs. This was based on a NIAID sponsored systems biology grant called SCRIPT, Successful Clinical Response in Pneumonia Treatment. And we've recently submitted some of our preliminary data on these patients. So this offered us the opportunity to compare COVID-19 patients to patients with other types of viral pneumonia, bacterial pneumonias, and a number of patients who had no pneumonia but had BAL to exclude it. And what you see in the top panel here is that there are two distinct groupings of patients, here with neutrophil dominant and here with paucity of neutrophils. And what you can see in all of the red bars at the top is that the COVID-19 patients tend to sort out into this subgroup. There are a few over here, and what our data suggests is that these are patients who have bacterial superinfection in their of their COVID-19. You also see the same appearance of increased monocytes that correlates with being with COVID-19 patients, and also increased CD4 T cells, CD8 T cells, and a decrease in tissue-resident macrophages. These are all seen in more graphic form here, where you see that in COVID-19, significantly fewer neutrophils than what we normally see, fewer tissue-resident macrophages. And if you look at the lymphocytes, significantly more CD4 and CD8 lymphocytes than what we see even in other viral pneumonias in the green here. And here's that higher percentage of monocytes that we think may be important in the pathogenesis of COVID-19. Now, this is the real money slide here of the patients. We had 134 patients who had a BAL done within 48 hours of intubation. There were another 53 who did not get an early BAL, either because they were external transfers or because their condition made it too dangerous to even do a bronchoscopic BAL. And this is the important number here. Only about 20%, or 1 out of 5 patients with COVID-19 at the time of intubation have evidence of bacterial pneumonia. If you look at the spectrum here, it is somewhat surprising. MSSA is a big player, at least for us, in COVID-19 infections, and then both strep pneumo and other strep species made up almost 50% of the bacterial pneumonias here. These other strep species were both on culture and on that BioFire assay that I mentioned earlier. Some other community-acquired pathogens such as H. flu, only one Enterobacterialis, that was a Klebsiella, that was pan-susceptible. So easily within the spectrum of what we see in community-acquired pneumonia. We had one HIV positive patient who had pneumocystis as well. So this spectrum supports the use of usual CAP treatment with ceftriaxone and azithromycin in the patients who have a high percent neutrophils. This is even true in non-intubated patients, and so the use of vancomycin and zosyn even on our non-intubated patients started to decrease as this data became available. We also could discontinue all antibiotics in patients who had a high proportion of lymphocytes, and that was true even if they remained febrile up to 102. And when we saw subsequent VAP, which is a significant problem in COVID-19 patients, at least the initial pathogens were highly drug susceptible. Now, the consequences were, interestingly, that if you were positive, there was a lower mortality, suggesting that maybe some of the respiratory failure in these patients was actually due to the bacterial pneumonia for which we have treatment. Early bronchoscopy was associated with better outcomes as well. Duration of ventilation, not so much. And so, in summary, we've demonstrated that bronchoscopy in COVID-19 is feasible and safe. We had no conversions with more than 15 fellows and more than 20 faculty doing these BALs. COVID-19 is characterized by lymphocytic alveolitis, and greater than 50% neutrophils suggest a bacterial superinfection. This early BAL in intubated COVID patients has important clinical impact, avoidance of antibiotics in many, narrow spectrum CAP antibiotics in some, and less selection for antibiotic-resistant pathogens when they do develop VAP. So thank you very much for the opportunity to present this preliminary data.